illness. He has been involved in various projects for many years and includes more than 50 clinical trials, and one of them was on endoxifen. Next slide, please. Borrowing from the Honda ad, olanzapine is the perfect fill it, shut it, forget it pill. So you fix a dose and you can stick it there. Do you see endoxifen, Dr. Jhavar, in the same category in psychopharmacology? Of course, offline as of now. Next slide, please. The third speaker is Professor of Psychiatry and Medical Superintendent at the National Institute of Mental Health and Sciences at Bangalore, Dr. Muralidharan Kesavan. He is one of the well-known experts who does research in the space of bipolar disorders, depression and brain stimulation and modulation in psychiatry. The question for Dr. Muralidharan is that quetiapine and lithium carbonate are the closest equivalents to a bimodal drug. To have a bimodal drug, do we need to have a unitary hypothesis, borrowing from chemistry, of course, in bipolar affective disorders? And is that a realistic target? Next slide, please. Then we have a debate by none other than Dr. For the motion, endoxifen is an effective weapon in real world psychiatry, by Dr. Devashish Ray. He's a senior reputed psychiatrist practicing in Calcutta since 1992, contributor to various national and international scientific journals. He has a very engaging approach. He has chaired several sessions, and he has won the Bombay Psychiatric Society Silver Jubilee Award. He comes to you from a very rich background. His interest is bipolar disorders. And opposing him is Dr. Avinash D'Souza, a well-known face in psychiatry based in Mumbai, the son of Dr. Alan D'Souza, the famous psychiatrist, over 300 publications in national and international journals. He's one of the few psychiatrists who, in addition to a psychiatry degree, has done an MBA in human resource development, a master's in psychotherapy and counseling, and an MPhil in psychology. He's also the editor of a journal called Indian Journal of Mental Health. For this debate, I have no questions to ask. To Dr. Anukant Mittal, who is the moderator and quiz master, I can afford to have no questions since he is a questioner himself. However, I might state here that we are going to have a prize for the best question, a prize for the most constructive critique, that is of course also indulging Pressy, and we are going to have the fastest finger forward 3 prizes, a first prize, a second and third prize, and Dr. Anukant Mittal at that time will brief you as to how it's going to be run. The quiz will be run before the question answer session. With that, I invite Dr. Andrade to start his session straight away. Dr. Andrade, please.
Can you hear me?
Yes, sir, you're audible.
And can you see my screen?
Yes, sir, visible.
So am I ready to go?
Yes, sir, please go ahead.
Yes, sir.
Thank you, Dr. Nagpal. Good evening, everybody. I have a very unusual topic, that of a devil's advocate. Effectively, I have been asked to present a critique on the use of endoxifen for mania. I will try and present a balanced perspective, but I will also illustrate the weaknesses of the data which the promoters of endoxifen will need to fill at both national and international levels before going from local to global, as Dr. Nagpal mentioned. Now let's start with a note about tamoxifen. Tamoxifen is not a new drug. Tamoxifen is more than half a century old. It was synthesized in 1962 as a selective estrogen receptor modulator. Initially, it was thought to be an estrogen receptor antagonist in breast tissues. But now it is recognized that what tamoxifen does differs on the tissue where the estrogen receptors are present. In breast tissue specifically, tamoxifen competes with estrogen, and therefore it is a very important treatment indicated for estrogen receptor positive breast cancer prevention and treatment in all stages of the disease, including stage 4 in which metastasis has occurred. However, and this is important for us who are using endoxifen, because what applies to tamoxifen also applies to endoxifen. Endoxifen is the active principle of tamoxifen. So, however, tamoxifen and hence endoxifen have agonistic action in bone and uterine tissues. This is good, for example, in bone because tamoxifen and endoxifen could reduce osteoporosis in postmenopausal women. Unfortunately, the unopposed action of estrogen in the endometrium and elsewhere in the uterus can increase the risk of uterine cancer and the risk of thromboembolic phenomena such as pulmonary embolism and deep vein thrombosis. So effectively, tamoxifen is antagonistic to breast cancer in estrogen receptor positive breast cancer patients, but behaves like oral contraceptives elsewhere in the body, such as for osteoporosis, uterine cancer, thromboembolic phenomena, and perhaps including the risk of migraine. Oral contraceptives increase the risk of migraine. Please excuse me. Sorry, I had to place my phone on mute. Now, the dose of tamoxifen for breast cancer has been 20 to 40 milligrams per day for a duration of 5 years. Why 5 years? Because an increased duration of exposure to tamoxifen is associated with a doubled or trebled risk of uterine cancer. However, a large study published in the Lancet about 7 or 8 years ago found that the benefits in patients with breast cancer exceeded the risks even with 10 years of tamoxifen treatment. This has implications for the long-term safety of the use of endoxifen in patients with bipolar disorder and mania. Now, why are we thinking of tamoxifen for mania? The reason dates back to the discovery that protein kinase C is a key enzyme involved in pathways, cellular pathways involved. Lithium and valproate are both protein kinase C inhibitors. And it was found are also protein kinase C inhibitors, thereby suggesting that if lithium and valproate can treat mania, then maybe tamoxifen and endoxifen can also treat mania. So the first study was published in the Archives of General Psychiatry in the year 2000, and it was a very small study. It was a crossover trial. After that, small as well as large studies have been conducted. These have been crossover RCTs as well as parallel group RCTs, where tamoxifen was administered in monotherapy as well as in add-on therapy along with mood stabilizers to treat patients with mania. And in all of these studies, tamoxifen was found to be superior to placebo. For example, 2 studies published in the Archives of General Psychiatry, year 2000, year 2008. Studies published by Jayashree Kulkarni from Canada in Psychoneuroendocrinology 2006 and 2014 a study published by an Iranian group in Journal of Affective Disorders in 2011, and by Carlos Zarate in Bipolar Disorders 2007. All of these are important journals. So this was an important drug studied for an important indication, in important research design, in important journals, and in all the studies, tamoxifen was found effective for the treatment of mania. And so that brings us to endoxifen. Tamoxifen is a prodrug. Tamoxifen is not an active principle. Tamoxifen needs to be activated by several CYP enzymes in the liver and elsewhere, especially 3A4, 2C9, and the most important of all, 2D6. 2D6 is perhaps the most important enzyme because 2D6 inhibitors prevent the conversion of tamoxifen to its active metabolite and decrease the efficacy of tamoxifen in breast cancer and for other off-label indications. So why use tamoxifen at all? Why not use its active metabolites, the most important of which is endoxifen? And that is where we are now in the use of endoxifen for the treatment of mania. There have been 2 randomized controlled trials which have been published. The first one in 2016, the second one in 2021, that is this year. The first study was a phase 2 randomized controlled trial published by Ahmed et al. Clinical Translational Science 2016. This was an industry-driven study. It was a study conducted in India. It was a study conducted in bipolar 1 patients, the sample size of 84 with 75 patients completing the study. These patients were randomized to receive endoxifen or valproate. Now, this study was described as a 2-stage study, each of 3 weeks duration. But if you actually read the research design in the method section, it was actually 2 randomized controlled trials where patients were randomized to receive endoxifen 4 mg per day versus valproate in a 2:1 ratio, or in the second stage, endoxifen 8 mg per day versus valproate in a 2:1 ratio. Now, in both of these stages, valproate was dosed at 1 gram per day, and the eventual sample size was 27 for endoxifen 4 mg per day, 28 for endoxifen 8 mg per day, and 29 for valproate 1 gram per day. In all 3 groups, statistically significant improvement was observed. YMRS scores decreased by 13 points with endoxifen 4 mg per day, by 16 points with endoxifen 8 mg per day, and by 16 points with valproate 1 gram per day. The response percentage was 55% improvement versus 55% improvement in endoxifen 4 mg versus valproate 1 gram per day. And the improvement was by 59% versus 65% in endoxifen 8 mg per day versus valproate 1 gram per day. There was no statistically significant difference between 2 groups in either of these 2 stages. The response rate was only 44% with endoxifen 4 mg per day, whereas it was 64% with endoxifen 8 mg per day and 72% with valproate 1 gram per day. And this seemed to suggest that not 4 mg but 8 mg of endoxifen per day would be a better dose for future study. Now, this phase 2 RCT had limitations. Curiously, the sample was not described. Baseline data were not provided. A consort diagram was not provided. The description of the research design as stage 1, stage 2 was puzzling because this was effectively 2 RCTs with 2 different doses compared against the same dose of valproate in separate stages. The statistical analysis was very simple and adverse events were not systematically reported. But this was a stage, it was a phase 2 study, perhaps forgivable, and this led to the phase 3 study of endoxifen for mania, published in a very important journal, Bipolar Disorders, by the same group of authors, Ahmed et al. In 2021. This was also an industry-driven study. It was conducted in India, solely in India, in 18 different centers in India. It was, like the previous study, a 3-week parallel group randomized control trial. There were 228 patients. So you can see this was a very large randomized control trial. It had a non-inferiority design conducted in patients with bipolar 1 disorder diagnosed by DSM-5. These patients, 228 patients, were randomized to receive endoxifen 8 milligrams per day. Sample size was 116 endoxifen patients, or to patients to receive valproate 1 gram per day, sample size 112 valproate patients. The sample was young. The mean age of the sample was 35 years at baseline, and the sample was 70% male. Patients were severely ill at baseline. The Young Mania Rating Scale score was 33, indicating that the patients were severely ill. That is, they had mania, not hypomania. Now, there's something curious over here. No patient required rescue risperidone or haloperidol to treat the mania, thereby disqualifying them from continuing in the study. And only 11% of the patients, and only from a single center, required SOS treatment with lorazepam up to 5 milligrams per day or up to 10 milligrams per day in the initial 10 days of the RCT. In other words, it appeared that endoxifen or valproate in themselves were sufficiently effective to treat mania in these patients. At the end of 21 days, the YMRS scores decreased by an almost identical margin in the two groups. Decrease was by 50%, and the improvement curves across the 3 weeks were almost identical with endoxifen versus valproate. The two curves almost overlapped each other, showing almost identical improvement at all stages of the clinical trial. The response rates were also almost identical. 49% responded to endoxifen versus 50% with valproate. Response being defined as 50% improvement in YMRS scores versus 34% with endoxifen versus valproate. Again, very closely similar, with patients showing remission from the initial 2 to 4 days itself, and improvements in CGI, Clinician's Global Impression, bipolar disorders, as well as severity, and the Montgomery Asper Depression scale, rating scales were almost identical in the two groups. There was only one dropout due to adverse events. The dropout occurred in the endoxifen group, but the paper did not provide details of the adverse event which resulted in the dropout. Apparently, there were no dropouts due to inefficacy or dropouts due to withdrawal of consent or other reasons. The consort diagram was not provided, but apparently there were no other dropouts. The rate of adverse events was very low, very similar between the two groups. The limitations of this study were that the consort diagram was not presented, so we don't really know the sample disposition. We don't really know about dropouts due to withdrawal of consent, due to inefficacy, or due to other reasons. There was no systematic assessment of adverse events. The adverse events presented in the study were those that were spontaneously reported. To answer Dr. Nagpal's question, which he posed to me before I started this presentation, what is astonishing about this study is that for patients with acute mania, baseline YMRS scores of 33, the response with valproate in a dose of just 1 gram per day was exceptionally good. 1/3 of the sample remitted in 3 weeks, and half of the valproate sample responded in 3 weeks with almost no benzodiazepine or antipsychotic rescue medication required. These findings appear astonishingly good, and I'm not sure whether they reflect real world practice. These findings require application. So those were the two studies on the efficacy of endoxifen. I on the efficacy of tamoxifen in this presentation, not on tamoxifen. So, and tamoxifen, there seems to be good evidence that it is effective in the treatment of mania. Endoxifen, there are two studies, a phase 2 and a phase 3 study, which suggest efficacy, but the quality of the data are not as good as was, and perhaps the sponsors of endoxifen can consider these suggestions for improvement in their future research. Looking at other issues about tamoxifen, where would we position tamoxifen? Now, we can't give valproate for women because valproate is associated with perhaps one of the highest rates of major congenital malformations after gestational exposure in pregnancy in neuropsychiatric practice. So, if valproate cannot be given to women, is it possible for tamoxifen to be given to women? Until today, um, I would say today because I completed making this presentation something like half an hour to 45 minutes before this seminar started. Until today, I thought that tamoxifen was used for treating breast cancer in women. It was used for 5 years to 10 years of continuous treatment. Tamoxifen has even been used as an alternative to clomiphene for conception in polycystic ovarian disease. So tamoxifen is used in women. It has been used for 5 to 10 years of continuous treatment in women. It has been used in large doses like 20 to 40 mg per day in daily treatment in women. It has been used to stimulate conception in PCOD in women. Then maybe tamoxifen is the answer or as a substitute to valproate for mood stabilization in women. We can't give valproate to women, so perhaps we can give tamoxifen to women. And then I came across this study which was published in Breast Care 2020 by Buonomo et al. These authors presented 3 cases of tamoxifen exposure during pregnancy, and they conducted a systematic review of the literature on tamoxifen use in pregnancy. And what they found was a very high rate of major congenital malformations. 12 major congenital malformations out of 68 live births for which full data were available. Looking at this, it appears that there is an 18% risk of major congenital malformations. This is unacceptably high. What we don't know is whether this number will still be 18% with endoxifen dosed at 8 mg per day. But we need to be careful because tamoxifen status is now contraindicated in pregnancy, with contraception being advised and with women being asked to wait for 3 months after stopping tamoxifen because they try to conceive. Is tamoxifen safe in lactation? LactMed 2021 data say that tamoxifen use in lactation is not recommended. Not only can it suppress lactation, but in women in whom lactation is not suppressed, tamoxifen is detected in breast milk, it accumulates in breast milk. Although it is a non-steroidal drug, it influences the effect of estrogen, and this has unknown potential to affect the baby. So it is not recommended during lactation. in addition to being contraindicated in pregnancy. Now, I told you that tamoxifen is like oral contraceptives in tissues other than the breast. So just the way oral contraceptives increase the risk of deep vein thrombosis and pulmonary embolism, tamoxifen has also been associated with an increased 5-year risk of DVT and PE that is roughly 2 to 3 times that of untreated controls. These data were published from a Scandinavian register obtained from a cohort study identified by Hernandez et al. In Cancer 2009. The American College of Obstetricians and Gynecologists in 2020 said that the risk of uterine cancer with tamoxifen may be increased 2 to 3-fold, with the risk being dose and duration dependent. The risk could be as much as 1% in tamoxifen-treated women as compared with 0.5% or less in untreated women. Now, if tamoxifen is a problem for women with mania, can tamoxifen be safely given to men with mania? Studies have shown that tamoxifen is reasonably well tolerated in men who are receiving the drug for gynecomastia after having developed gynecomastia because of anti-androgen therapy given for prostate cancer. This study was published in Andrology in 2016. This review was published in Andrology in 2016. What we don't know is whether this safety of tamoxifen in prostate cancer generalizes to endoxifen use in men with bipolar disorder, either bipolar 1 or bipolar 2 disorder. Good points are that sedation is not expected with tamoxifen, tremor is not expected with tamoxifen, weight gain is not expected with tamoxifen. All of these problems are expected with valproate. One problem, though, is that just the way oral contraceptives may raise cholesterol levels, so too tamoxifen can raise serum cholesterol. And in fact, the Ahmed study 2021, published in Bipolar Disorders, found that there was a 10 milligram per DL increase in total cholesterol from 156 to 166 in association with endoxifen 8 milligrams per day. Is tamoxifen safe in patients with epilepsy? The answer is yes, tamoxifen is safe in epilepsy. In fact, tamoxifen may increase the seizure threshold as found in a case report of a patient who was receiving ECT. There are no data on tamoxifen or endoxifen taken in overdose, but it is probably safe. Coming to the end of my presentation, tamoxifen has a half-life of about 5 to 7 days. Endoxifen has a shorter half-life, but also long relative to other psychotropic drugs. The half-life of endoxifen is 2 to 3 days. Endoxifen is minimally metabolized by CYP enzymes. It is converted to norendoxifen, but the bulk of endoxifen is metabolized by UGT and by sulfation, that is by non-CYP processes, and is eliminated. Endoxifen and tamoxifen both stay in the body for long because of a prolonged enterohepatic circulation. So ending my presentation with a summary, endoxifen is a novel intervention for mania. It is a potential alternative in the treatment of mania, an alternative to second-generation antipsychotics, an alternative to valproate, carbamazepine, and oxcarbazepine. It gives us a new treatment option for patients with mania. Where do we need to study further? We need to see whether higher doses of endoxifen have greater efficacy. We need to see whether endoxifen is also a good treatment for hypomania. So far, tamoxifen and endoxifen have been studied in bipolar 1 disorder. Bipolar 2 disorder is also a large problem in the population, and hypomania needs to be treated with appropriate agents. We need to see the efficacy of endoxifen as a maintenance treatment agent. So tamoxifen has not been studied in maintenance therapy. Endoxifen has not been studied in maintenance therapy. We need to see the long-term safety and efficacy of tamoxifen and endoxifen alone and in combination with other mood stabilizers for bipolar 1 and bipolar 2 disorders in different doses. The long term safety requires formal assessment using structured assessments for adverse effects separately in men and women because endoxifen, even though it is non steroidal, it does affect hormones. With this, I conclude my presentation. Thank you for listening.
Thank you, Dr. Andrade. Your summary slide, in fact, seamlessly weaves into Dr. Venugopal Jhawar's presentation because it talks about the practical aspects of treating bipolar disorder, including hypomania and the bipolar depression. It also talks about the maintenance therapy. So I think Dr. Jhawar will now take up these issues which you have shown in the present. A very erudite presentation, Dr. Andrade. We are indeed very impressed. Thank you very much. Dr. Jhawar, please.
Good evening.
Good evening, sir.
Thank you, Dr. Andrade, for that wonderful presentation. It was very informative and very apt, and especially where you presented both the studies, both the 16 and 21 by Ahmed Group and industry sponsored, does make a lot of sense for us to basically to move from here. My topic is I'll be not very going in detail. I had been asked to speak about the real world experience, which is, I think, came out of the organizers must have thought because I was part of the trial and I'm using Zonalta from day one. So I think that must have been the reason for them to ask me to speak on this. Just to set tone and set pace to the speaker. Are the slides visible?
You need to go on to the
Slideshow mode, please.
Yeah,
slideshow mode.
just a minute, just a minute. Is it okay now?
Yes, sir.
Okay. Now, this is what we have experienced recently. In spite of everything, this is what is experienced. And same happens with most of the drugs which come new. What we experience and what we do, eventually that come out after about 5 to 10 years minimum it takes so that we realize what the things are. And this is the real world, what compared to the experience, what it has done, number of lives we have lost, number of students who have, number of teachers and everything, the economy and whatnot has been impaired. So taking this to our Zonalta experience, endoxifen is now Zonalta. I was part of phase 3 in 2018. I feel good for certain reasons. The first ever psychotropic of relevance fully made in India. The first ever anti-manic drug made in India other than what we had in our traditional medicines. Being part of the trial was a good experience to know the product in detail. Than my experience. These are certain set of questions. I had two more, but I could not find them. This was all when I used to do DNB, when DNB was done at our centers. And I had these are the questions they keep on asking. Some of them used to be, some of them, I really like them. Some of them that why don't we use antipsychotic as stabilizers? When subtypes of schizophrenia have waned in new DSM, why can't this mania? We already have mania, depression, mixed state. Depression is already an established entity, then why bipolar depression, all these things. So these are the questions which comes to young mind. And as far as the pharmacology is concerned, we need to have answers as based on the pharmacology. Zonalta. We took about 48 subjects. I think 2 subjects initially, but they did not continue. As far as I remember, there was no SAE. We had a couple of A's which were headache, nausea, and vomiting. Trial overall went smooth. It was our first experience to work with an Indian CRO, and it was okay. By and large, it was okay. And the protein kinase C signaling, which we see here. There are few important related facts which needs a lot of attention. I do not understand why we did not apply tools for scales and movement for movement disorders. That was something very, very striking for me, that we had YMRS, we had scales for depression, and we had CGI S and CGI I, but we did not include any scale for movement disorder. The onset of effect was not very predictable as compared to other drugs. We could not take severely manic patient as we typically see in our daily OPD, which Dr. Andrade pointed out, that may impair or may adulterate the basically the final outcome. In some patients, I did feel the need of going up to 10 to 12 milligram of endoxifen. In past few studies, as Dr. Andrade has already pointed out, they have used tamoxifen alone and as an adjunct for the treatment of mania. They have by and large, all of them, most of them, and they were in good journal and good studies that tamoxifen was effective. Endoxifen being the most active metabolite is the drug which we are using. Ever since endoxifen became Zonalta, I'm using it regularly for mania with or without psychotic symptoms. Starting only 8 milligram. I've never used 4 milligram for mania yet. Some couple of interesting experiments which I did. One is just very recently, a guy who was basically recovering from COVID and used steroid for almost 8 9 days and had mania. I used 4 milligram and got a reasonably okay response in 4 days. So that is a very, very honest thing which I did and I'm sharing with the group. I find it good drug for women where I cannot use valproate because of obvious limitations. And oxygen seems to be good choice. I'm finding it better for those who cannot tolerate valproate for various reasons, for tremors, for increased blood urea nitrogen, for ammonia, for other reasons. There are certain population where we would like to avoid olanzapine. Dr. Nagpal did ask a question regarding the Honda ad, fill it, shut it, forget it. It should be a good drug where we are significantly concerned for metabolic profile. It should be a good drug. One of the best part is once a day dosing is extremely convenient. We can safely avoid anticholinergics. I would like to, I had gone through this journal, this particular article. I would like to say, because as Dr. Andrade said, and as we know that both lithium and valproate also are PKC, these things. So we basically, I think future research is certainly warranted that we need to develop and we need to understand more about role of drugs like TMS, tamoxifen and endoxifen in treating manic symptoms, particularly in humans. This is some kind of real world which I've been doing for last month or so. I used endoxifen in 2 patients of traumatic brain injury sequel exhibiting severe behavioral problems, and one of them where grandiosity was very prominent. One guy is doing okay and the second one is yet to report. This guy was actually difficult to manage. He was already on some 800 or 900 milligram of valproate. I don't remember exactly the dose of valproate. He was on olanzapine. I did not stop other drugs. I added endoxifen to that. Recently used that I already shared 4 milligram of this thing, COVID-19 patient who had mania. I used 4 milligram of endoxifen in a young engineer, 29-year-old, just 10 days ago, suffering from severe game addiction. I don't know. And I'm used for 3 patients for hypomania, 4 milligram per day. Results are still awaited. What I would like to see and learn more about is that can we use it for conditions like gambling, learning disabilities, especially associative learning linked with hippocampus, combining with conventional mood stabilizers, rational polypharmacy, doing some kind of rational pharmacy, because we have seen that in long term, no single stabilizer works. We either add lithium with valproate, lithium with carbamazepine or oxcarbazepine, and obviously lithium and lamotrigine. And for those patients who have comorbidities, these are certain areas, it's not all good. There are certain problems which I face till date. And one of them I shared in real time with Dr. Nagpal, if Dr. Nagpal remembers. Two patients developed EPS. One of them developed frank EPS, where there was tremors, there was salivation, and patient was in discomfort. I had to admit patient for 3 days, and he was only receiving 8 milligram of endoxifen. He was not receiving any other drug. He was earlier receiving olanzapine and valproate, but which had been stopped. After we had stopped olanzapine and valproate, 4 days later, I put him on 8 milligram, and 7 days later, he developed EPS. Dryness of mouth, I'm seeing pretty frequently. Onset of action is very, this is something which I am really not very comfortable with, because sometimes it takes 7 days, 8 days, 4 days. So if somebody we are treating, because in my OPD, I see still those patients, those manic patients who are brought in chain. I take photographs with the consent, keep on sharing with my close friends. They're brought in chain. YMRS is almost 45, 50. Is it a drug for those kind of population? I'm not sure. Or I would be comfortable in saying that, no, I'm not confident. So it is probably a drug which would somewhat say about YMRS of 25, 30, 35 in that range. And where are those who are not very disruptive, where we can use the drug? Yes, certain advantages which have been discussed. Dr. Andrade has very clearly explained most of the things. With this, I end my presentations, and just a small invitation. Our annual event, DevaCon, this year we'll be doing in September, and last year we could not do it because of COVID. So I think now I rest my presentation here. Over to Dr. Nagpal.
Thank you, Dr. Jawar. I liked your expression of patients as guys. This is the first time I've seen that. I like your reference to the word mood stabilizer, which Dr. Muralidharan would talk, which Professor Kesavan would certainly talk about. I like the. I'm a little intrigued by the issue of the EPS, as we discussed even the earlier time.
Yes.
That was it a late effect of the olanzapine which you withdraw, because the protein kinase inhibitor causing EPS, to my mind, doesn't make any neurobiological understanding at all.
I did search. I could see one case report which I am not very clear, but they say movement disorder with tamoxifen. And I think a day or tomorrow I can share that, then you can share in the group.
Thank you. And the last thing I liked about was onset of action. Yes, the studies, initial phase 3 studies showed onset of action as early as 4 days. In real life, of course, I don't have the experience as actually you do, but in my limited knowledge also, we are not getting response as early as 4 days if you're using endosophin standalone. So that's another issue which will require a good phase 4 study. INTAS, I hope, is actually hearing us out. A good phase 4 study to sort out this very important issue. And with that, I would now request Dr. Muralidharan Kesavan,
Thank you.
Psychiatry at NIMHANS, to present a very interesting topic. It's a philosophical topic, basically, at the heart of the unitary hypothesis of bipolar disorder, at the heart of the neurobiological mechanisms. And it is a dream child for every psychiatrist to have a bimodal drug. Dr. Muralidharan, please.
Thank you, sir. I hope I'm audible.
Yes, sir.
And visible.
Yes, sir.
Thank you so much, sir. So, a very good evening to all who have joined the talk today. Like Dr. Nagpal said, I'm going to be talking about Is there a bimodal drug which is feasible for bipolar disorder? And at the outset, let me start by disclosing that I have no conflicts of interest, and I'd also like to thank Banai for this opportunity. I'm talking about a topic other than COVID 19 after a long time, so I really thank the Banai team members for this opportunity. We'll have to be talking about bipolar disorder once again. So this is one of my favorite slides that I use in my presentation. Uh, Basically, as far as psychiatry and psychiatrists are concerned, bipolar disorder has been to schizophrenia what Rahul Dravid has been to Sachin Tendulkar. Equally important, equally well accomplished, but less recognized. So, in that sense, I really think I thank Banai for organizing a talk on bipolar disorder exclusively. And I wish to see more talks about bipolar disorder, and bipolar disorders will get the importance that they deserve. So just to set the context, we all know that there are different polarity of episodes in bipolar disorder. There are some significant challenges. The most important challenges that we face are incomplete recovery from episodes, inter-episodic symptoms. There are a lot of patients who experience breakthrough episodes. In addition, patients with bipolar disorder tend to have cognitive deficits. Psychotic symptoms may occur both in manic episodes and depressive episodes. Poor functional outcomes are something that we see very commonly, and comorbidity seems to be the rule rather than exception in bipolar disorder. In terms of the evidence for treatment, we have to contend with limited data. A lot of these results are unreplicated. Some trials that we see have unrepresentative samples and very different from what we actually see in real world situations, like Dr. Venu mentioned a little while ago. Some of the drugs also come with small sample sizes, which makes it difficult for us to accept the results. In terms of treatment options for bipolar disorder, what are the challenges that we face? The options are very limited. You could even count the number of drugs that are available to treat bipolar disorder on your fingertips. Most of the options that are available are unimodal. They work either for mania or for depression. Very few of them actually work for both. Some drugs tend to exacerbate the other mode of symptoms. We are aware of how antidepressants can cause a switch in bipolar disorder. And likewise, we know that there are treatments for mania that can cause depressive symptoms, like aripiprazole, for example, which has been documented. Most of the available treatments for bipolar disorder tend to work for elevated mode, in the sense that they stabilize mood from above. In addition, we have poor treatment response seen in almost 35% of the patients treated for bipolar disorder. And the last but most significant challenge that we face is side effects. In a disorder where treatment has to be lifelong, or in a disorder which is chronic, side effects can actually sometimes impair our efforts to treat the disorder and may significantly affect compliance in patients. So, to go on to the outline of my presentation, I'll be talking briefly about what is the definition of a bimodal drug and a mood stabilizer. I'll review some of the evidence for bimodal drugs and end the summary statement. So, what is a bimodal drug? I tried to look for literature that actually uses this term bimodal drug or a bimodal treatment, and I came across one of these published about 2 decades ago in a psychopharmacology bulletin. Basically, when we talk about bimodal drugs or bimodal treatments, we talk about a drug that works equally well for acute mania and depression and bipolar
Just a
disorder.
minute.
So, what is a mood stabilizer? This is a question that we keep asking ourselves. This is a question that even Dr. Venu asked in his presentation a little while ago. If you look at what a mood stabilizer is, this is a term that has been used more in common parlance. There's actually no scientific definition for this term. And interestingly, this term was first used for the drug chlorpromazine, even before it was used for lithium. So the definitions of mood stabilizer that we understand are a drug that is effective in mania, depression, and in preventing both manic and depressive episodes. One of the older definitions is a drug that has efficacy in decreasing the frequency and severity of any type of episode in bipolar disorder. And if it does not worsen the frequency or severity of other types of episodes. So both these definitions have been in use for some time. Now, let's look at some of these important articles that I thought I should share with us. So this is an article that was published in 2004 by Trevor Young. the question as well as the title of the article are saying what exactly is a mood stabilizer. So some of the points that were raised in this article include, so how do seemingly different classes of medications have a common domain of efficacy? This was in the context of lithium and some second generation antipsychotics being found to be effective in the treatment of mania and bipolar disorder. In fact, this article went on to say that defining a drug as a mood stabilizer may not be as important over time as identifying the clinical profile of the patient and matching the clinical profile of the patient with the drug. So the understanding was that, okay, it doesn't matter what you call the drug. It's important that we need to match the profile of the patient with the drug. Is a patient currently in a depressive episode or a manic episode or a mixed episode? And how do we match them with the drug that is available? The article also asked us to look at if there are shared mechanisms of action with lithium and valproate and if this is shared by other drugs too. And this is something that has been referred to by the previous two presenters, where the mechanism of action of endoxifen has been compared to that of valproate and lithium. Another article that was published in the year 2004 in American Journal of Psychiatry also talks about not having a consensus definition for a mood stabilizer. They came up with a proposal that an agent may be considered as a mood stabilizer if it has 4 distinct uses, or a 2x2 model: treatment of acute manic symptoms, treatment of acute depressive symptoms, prevention of manic symptoms, and prevention of depressive symptoms. So, based on this criterion, they decided, by examining all the drugs that were available at that time, that only lithium met the criteria for a mood stabilizer. That was in the year 2004. Now, cut to the year 2018. We would think that we have a better definition of mood stabilizer that would have evolved over the last 2 decades, but looks like we don't have. This article again talks about defining what a mood stabilizer is and to come up with a novel framework for clinical practice which could be used to define a mood stabilizer. Now, what this article tells us is that many nondescript medications are classified as mood stabilizers. Sometimes drugs that are effective only in treating mania or treating depression or just in the prophylaxis against manic episodes are given the term mood stabilizer. The article also mentions an important point that we cannot abandon the term mood stabilizer because of its widespread use in clinical practice. So they go on to talk about a similar model that was described in the previous study that I mentioned, a 2x2 model, looking at how good a drug is in treating acute mania, treating acute depression, in the prophylaxis against manic episodes and depressive episodes. So, what are bimodal drugs and mood stabilizers? All mood stabilizers are also bimodal drugs. Now, this is something that I found very, very appealing, and I thought I should share it with all of us. Mood stabilization is actually an aspiration that patients, their families, and attending doctors probably share. And if a medicine were to assist in achieving this ultimate goal, then doctors are more likely to prescribe such a treatment and patients are more likely to take it. So with this particular theme in mind, let us go on to review what is the evidence that is available for the use of bimodal drugs in bipolar disorder. I'm not going to be touching too much about maintenance treatment because that would take away a little bit from the focus of my presentation. So I'll just focus on drugs and the role of these drugs in treating acute depressive episodes and acute manic episodes in the course of bipolar disorder. So where do I start? So this was a difficult question for me. So I thought, let me start with what CANMAT guidelines recommend as maintenance treatments for bipolar disorder, and particularly focus on those drugs that have been classified as first-line treatments. As we are all aware, CANMAT guidelines have also used the hierarchical rankings of drugs. So they kind of rank the drugs in terms of the available evidence for maintenance treatments. So from this particular chart, I took the role of these drugs in treatment of acute depressive and manic episodes, and I thought I'd review the evidence for each of these drugs briefly. So lithium. We all know that lithium has been in use for over 60 years, one of the drugs that has been discovered exclusively for bipolar disorder. Most of the other drugs that we have for the treatment of bipolar disorder have been borrowed from the treatment of schizophrenia. So this is probably the only drug till date that has been developed for treatment of bipolar disorder. So one of the recent review articles that spoke about lithium and bipolar disorder summarized the evidence. So basically, in terms of mania, we have a meta-analysis by Cipriani et al., which showed an effect size about 0.40. There's another study which showed comparable efficacy of lithium at 0.8 to 1.2 milliequivalents per liter to quetiapine over a 12-week period. The important thing to remember now is that lithium has started playing a secondary role to second generation antipsychotics in the treatment of mania, probably because of a longer time to optimal action, because of less sedation that is seen with lithium and more with SJs, which are quite effective in the early phases of treatment in mania, where the sedation is also used to help keep the patient calm. In addition, the narrow therapeutic window of lithium always is a challenge for clinicians. And if we don't ensure that the lithium levels are within the therapeutic window, then the efficacy can become lesser. In terms of depression, what we know is that there is no clear evidence. And lithium has been shown to be no more effective than placebo and less effective than venlafaxine in treating bipolar depressive episodes. But in terms of guidelines, the recommendations are divided. While the CANMAT guidelines and the Australian New Zealand College of Psychiatrists guidelines for mood disorders do recommend lithium as a first-line treatment for both mania and bipolar depression. The World Federation Societies of Biological Psychiatry guidelines recommends lithium plus a second-generation antipsychotic for the acute treatment of bipolar depression. So there seems to be some kind of a lack of consensus on the role of lithium in treating acute bipolar depression. Moving on to quetiapine. So we know that quetiapine has been seen as the next best thing to have happened to bipolar disorder after lithium. In fact, you could say that it's taking a claim to the throne that lithium has occupied for so long in terms of treating bipolar disorder. In acute mania, there are 4 quetiapine trials which have tried the drug in doses of 300, 400, and 600 milligram per day. The findings are that it is more efficacious than placebo in treating acute mania. The important thing to note with quetiapine is that the onset of action is quite rapid, and usually within 4 to 5 days, you can see some symptomatic relief that is happening, and even rapid up titration is possible. In terms of treating bipolar depression, there are 3 or 4 RCTs, and there are there is one meta-analysis which combined these RCTs. And in the study by Young et al., we had quetiapine in doses of 300 milligram and 600 milligram, 2 arms, and lithium between 600 to 1800 milligram per day compared with placebo. And quetiapine in both doses was found to be more efficacious than placebo in treating bipolar depression as compared on the change in MADRS and Hamdi scores at the end of 8 weeks. The study by McElroy et al. Also compared quetiapine and paroxetine with placebo, and they came up with similar results. So quetiapine at doses of 300 to 600 milligram per day has been found to be quite efficacious in treating acute bipolar depression. So moving on to valproate. Valproate is one of the earliest treatments that has been approved for mania. All the guidelines that we refer have recommended it as an acute, as a first-line treatment for acute mania. However, the role in bipolar depression appears to be limited. There is a meta-analysis that was published in the year 2010 in Journal of Affective Disorders, which looked at the efficacy of valproate in treating bipolar depression. They reported a small to modest effect size in terms of the ability of valproate to bring down depressive symptoms on MADRS scores. The important thing that we need to see here is the sample sizes. The number of subjects in both the arms were quite small. In fact, I think it's only about 140 subjects were recruited as a part of these 4 studies. So that's something that we need to take with a pinch of salt, which is why most guidelines don't recommend valproate as a first-line treatment for acute bipolar depression. The other thing that we need to remember is that of late we're coming across a lot of case reports that talk about whether valproate could be causing depressive symptomatology in patients remitting from acute mania. Like I said, if that is the case, then it needs to be viewed with a lot more circumspection. Lamotrigine, one of the drugs that has been recommended for the use in bipolar depression. Now, what about the role of lamotrigine in mania? In mania, there are about 4 trials that we could come across. Most of these trials have used low doses of lamotrigine and short duration of trials. The short duration of trials, most of the mania studies usually look at 3 weeks or 4 weeks of, the trial is only for 3 or 4 weeks. So in lamotrigine also, the trials that I came across are mostly 4-week trials. We all know that lamotrigine takes a long time for up titration to the desired dose. So most of the studies have looked at only 50 mg or 100 mg of lamotrigine. In some of these studies, lamotrigine has been used as an adjunctive to second generation antipsychotics. And that again it's difficult for us to interpret the results. So lamotrigine has not been found to be efficacious in mania. In terms of depression, again, the evidence for lamotrigine was not great till this meta-analysis was published in the British Journal of Psychiatry, which showed that individual data from 5 different trials were combined, and was found that lamotrigine was significantly more efficacious than placebo in treating acute bipolar depression. In fact, this was found to be more with those patients who had severe depression as per the Hamilton Depression Rating Scale. So those with score of greater than 24, it was found that lamotrigine was significantly more efficacious in those. It doesn't mean that, well, lamotrigine works better for severe depression. It only means that the placebo response was probably higher in the patients who had less severe depression. So placebo response was one of the things that was a challenge in patients with lamotrigine, simply because the duration of the trial and the low the speed at which we can uptitrate lamotrigine makes placebo response quite common. Asenapine, what is the role of asenapine in treating bipolar disorder? Is it a bimodal drug? Now, there are 3 trials of asenapine and acute mania. Comparable efficacy was seen with olanzapine. It had significantly greater efficacy than placebo in these trials. Asenapine has been used in doses of 5 to 10 milligrams per day, sometimes 15 milligrams per day in these trials. The important thing is that it had comparable onset of action with olanzapine, with onset of action reported as early as 2 days and 4 days. In terms of depression studies, there was no change in MADRS scores that were reported in all of these trials, especially those trials that looked at subjects with mixed affective episodes. So, a post hoc analysis of these studies was done and published in Journal of Clinical Psychiatry in 2015. The post hoc analysis does show that asenapine was significantly more efficacious than placebo in bringing the depressive symptoms, in bringing down the depressive symptoms from the 7th day to the 21st day, as measured on the Montgomery-Åsberg Depression Rating Scale. However, it did not significantly differ from olanzapine. The difference between placebo and asenapine was quite significant. So this review says that yes, asenapine is a drug that could be tried in the treatment of acute bipolar depression. Aripiprazole. Now, aripiprazole is a drug that we use extensively in clinical practice. But what is the evidence that is available for the role of aripiprazole? So there are 4 acute trials in mania, in acute mania. Compared to placebo and haloperidol, these are the other 2 arms in these trials. Significant efficacy was noted at doses of 10 to 30 milligrams per day. In terms of bipolar depression, there are 2 RCTs. These RCTs did not report any separation from placebo at 8 weeks at the end of the study. Now, in both these RCTs, some encouraging trends in terms of separation from placebo was noted between week 1 to week 6. But the separation did not last at 8 weeks. So aripiprazole was not found to be efficacious in treating bipolar depression. Now, again, like asenapine, a post hoc pooled analysis was done, which reported that in more severe cases of depression, aripiprazole in flexible dosing of 5 to 30 milligrams per day was slightly more efficacious than placebo. However, the role of aripiprazole in treating depressive episodes is not there. So it has not been found to be beneficial in preventing depressive episodes. Lurasidone. This is the drug that has been in practice for the last 5 to 6 years in India, a lot longer in North America and Europe. So there are no trials in acute mania. As far as I'm aware, there's one unpublished trial which reported a trend to significance in acute mania. It looks unlikely that a repeat trial with lurasidone is likely to happen. However, in terms of treating acute bipolar depression, it has been found to be efficacious. The network meta-analysis was published a few years back, which compared lurasidone with other second-generation antipsychotics and placebo, and it found that lurasidone was significantly more efficacious than placebo, aripiprazole, and ziprasidone, while as far as olanzapine and quetiapine were concerned, it had comparable efficacy in terms of bringing down the depressive symptoms on MADRS scores. And in terms of remission, which was defined as MADRS score less than or equal to 12 at study endpoint, the results were quite similar. Lurasidone was found to be more efficacious than placebo, aripiprazole, and ziprasidone, slightly more efficacious than olanzapine, though not significantly, and had comparable efficacy as quetiapine. So the role of lurasidone in treating acute bipolar depression is quite well established, whereas there is no evidence for the use of lurasidone in acute mania. Cariprazine, again, another drug that is now available for the treatment of bipolar disorder, still not available in India. We have this meta-analysis that was published a couple of years back, which looked at cariprazine in treating mania. They have the analysis that is here. The analysis A actually is cariprazine at 3 to 6 milligram per day dosage, and the analysis B is cariprazine at 6 to 12 milligrams per day, and at both these doses, it was found to be significantly more efficacious than placebo in treating acute mania. So, how does it fare with bipolar depression? Yes, now the analysis A is cariprazine at 1.5 milligrams per day, and analysis B is at cariprazine 3 milligrams per day. And at both these doses, cariprazine was found to be more efficacious than placebo in treating acute bipolar depression, though it was not statistically significant. So there was a trend to significance. There was a decrease in the depressive symptomatology, but the efficacy is not like what was reported in mania. Clozapine. We all know that in the end, we all come down to clozapine, and many of our patients who don't respond to the other second generation antipsychotics actually do well with clozapine. So I looked at this systematic review and meta-analysis, which was published in the year 2020. And the evidence that is available that has been synthesized in this particular meta-analysis, this tells us that there are many RCTs that have looked at clozapine versus other second generation antipsychotics in treating acute mania, and it was found to have comparable efficacy in treating acute mania. Now, this is not treatment resistant mania, this is just acute mania. However, there's another article which has looked at the role of clozapine in treatment resistant bipolar disorder. In treatment resistant bipolar disorder, clozapine was found to be associated with significant improvement in manic symptoms and depressive symptoms, rapid cycling, as well as psychotic symptoms. Also helped bring down suicidal aggression, and so this was in treatment resistant bipolar disorder. So clozapine appears to have a role in the treatment of acute mania and a more definite role in the treatment of treatment resistant bipolar disorder, including treatment resistant bipolar depression. So to summarize the drugs that I've discussed so far, in terms of bimodal drugs, to go back to the article that was published in 2018, we are still far from a consensus definition of a bimodal drug. We still don't have a drug that is equally efficacious in treating mania and depression. Going by the evidence that I have presented so far, only quetiapine appears to have some evidence, conclusive evidence, in terms of treating both acute mania and depression, whereas most of the other drugs seem to have more efficacy in one pole than in the other pole. So the search for bimodal drugs continue. If you look at this particular diagram that is from the same figure from the same article, you can see that quetiapine appears to be the only drug that can be called bimodal, whereas lithium and lamotrigine, lithium comes close, whereas lamotrigine is nowhere close to being a bimodal drug. So in terms of those drugs which can be considered bimodal, lithium and quetiapine probably the most bimodal drug than most of the other drugs that we have in the armamentarium for treating bipolar disorders. Lithium and valproate also have some amount of demonstrable bimodal activity. However, if mood stabilization is required, including prophylaxis against manic and depressive episodes, then lithium and quetiapine probably rank higher than all other drugs. So what do we do in India? Do we use bimodal drugs? What exactly do we do? Again, I'm just referring to this article that was published in Australia, New Zealand Journal of Psychiatry, and some of our distinguished speakers today are also co-authors in this study. So in this, which reviewed the prescription practices from 500 psychiatrists registered with the Indian Psychiatric Society, they looked at some of these aspects of treatment of bipolar disorder. And what did they find? We find that most of the psychiatrists interviewed, almost 54% of them, say that in the treatment of acute mania, they will use a combination of a mood stabilizer and an atypical antipsychotic. Antipsychotic alone is chosen by only about 8% of the psychiatrists that were polled. And that's probably what reflects real life practice in terms of treatment of bipolar disorder and the role of bimodal drugs. As you can see, a combination of a mood stabilizer plus an atypical antipsychotic seems to be the first choice drug. And how do we fare when it comes to treating acute bipolar depression? Again, the first preference appears to be mood stabilizer plus SSRI, contrary to what most guidelines say. This is followed by mood stabilizer plus quetiapine. And if you look at the drug that has the most efficacy in treating acute bipolar depression, which is quetiapine, only about 9% of Indian psychiatrists use it as a standalone treatment or monotherapy in treating acute bipolar depression. So this is quite reflective of the challenge that we have in terms of identifying bimodal drugs and treating bipolar disorder, and the prescribing practices of psychiatrists in India actually seems to reflect this challenge. So, what about rational polypharmacy? Whether we accept it or not, whether guidelines talk about it or not, that is what is widely practiced. We know that in terms of acute mania, almost all of us tend to use a combination of second generation antipsychotic plus a mood stabilizer. Mainly because the mood stabilizer tends to take a longer time for action, and we need more acute effects in patients who are florally manic. In terms of acute bipolar depression, yes, a combination of a second generation antipsychotic like quetiapine plus mood stabilizer or a second generation antipsychotic plus an SSRI is something that is used quite commonly. Combined efficacy of these drugs has been demonstrated to be greater than monotherapy, and monotherapy for acute mania and acute bipolar depression, while recommended by guidelines, do not actually translate into clinical practice. So that is something that we must all accept. The rational polypharmacy is what is most widely practiced in the treatment of acute mania and acute depression. So in conclusion, a bimodal drug, while it is ideal for bipolar disorder, there is only limited evidence. Most studies that I've reviewed today are quite old, particularly drugs that have looked at lamotrigine, studies that have looked at olanzapine, studies that have looked at valproate, including studies on lithium, are all quite old and need to be rethought and revisited. Most of the analysis for drugs that talk about its role in acute bipolar depression are pooled analysis. They have been done to support the efficacy of these drugs. Whether they actually translate into real-world efficacy against bipolar depression remains to be seen. They don't seem to be very popular, particularly drugs like asinapine and aripiprazole for bipolar depression. Polypharmacy appears to be the real-world norm for acute treatment of bipolar disorder. And with the available evidence, bimodal drugs do not appear feasible for bipolar disorder. So with these words, I'd like to end my presentation, and I'd like to thank Banai once again for this opportunity to share a very interesting talk. Thank you so much.
Thank you, Professor Kesavan. It's been enlightening hearing you out. It's a very sensible, evidence-based, state-of-the-art presentation. I like the mix of rational polypharmacy and evidence-based medicine. I liked the Indian touch to it. I liked the application of the Indian experience to the entire talk, how that reflects the real world treatment of mania and depression. I like the summary and I like the end of it where it states that it might not be feasible because the unitary hypothesis of bipolar disorder is possibly not there. There appears to be different mechanisms for both. With that, now we move on from this very interesting talk with Dr. Kesavan to a debate, and the debate is whether endoxifen would fit the bill for the treatment of mania or not. And we have two stalwarts. We have Dr. Avinash D'Souza and we have Dr. Debashish. So Dr. Debashish will speak for the motion. It will be a 20-minute duration for the first presentation, 20 minutes for Dr. Avinash D'Souza, followed by a 7-minute kind of counterpoint presentation each. Over to you, Dr. Debashish.
Hi, good evening. Let me share my slides. I'll have to. Are the slides visible now?
Yes, sir.
Yes, thanks. So I'm supposed to, support the view that endoxifen is important in real world psychiatry. Now, this is beyond doubt that endoxifen is a very essential molecule, a new molecule in in bipolar psychopharmacology. That doesn't mean that endoxifen is going to fit in all the bipolar disorder patients. Bipolar disorder himself, as Dr. Nagpal was also telling, neither the unitary hypothesis, probably not even a binary hypothesis. Possibly we are looking at multifactorial, and definitely a polyneurochemical disorder whose clinical presentation may not be so, it's not so black and white. There are several gray areas in between. And just because of this, we are still quite frustrated in the pharmacological treatment of bipolar disorder. What happens when we practice in India? I have little experience in practice, but whenever we practice in India, we do not practice real world psychiatry. Firstly, most of our prescriptions are pharmaceutically driven. Our knowledge becomes pharmaceutically driven. You would be probably remembering how Eli Lilly was, promoting olanzapine in bipolar disorders. Now, there may be individual bias. A person may not like the color of the risperidone tablet. The other person may not like the shape of divalproex. And an immense patient load because of our population. Then we have what we have to prioritize in treatment. When we are writing a prescription, what is our goal? What we are going to achieve by these medications? Most people are actually focusing only on symptom resolution. One, maybe avoiding side effects, but what gets neglected is the functional recovery, the cognitive, the cognitive status, and how this person, even when he's not having symptoms, can be rehabilitated properly. So we have a half-baked psychopharmacology still in bipolar disorder. Then there is this academic and clinical dichotomy. A lot of people in India would practice what they call the experience base, and there is definitely the evidence base. Sometimes too much evidence will confuse your daily practice. And, the poor socio-political infrastructure that we have in our practice throughout this country is something which is standing in the way of our, giving the, facing the realistic real world is, almost an elusive El Dorado. What does the patient want when we prescribe? They want to get rid of their symptoms as quickly as possible and as fully as possible. There should not be a residual symptom. Safety and tolerability. There should not be any relapse or recrudescence. The medicine should be cost effective, and they would be, whenever they're taking any other medicines for either other psychiatric comorbidity or for physical comorbidity, there should not be any interaction, or the interaction should be minimal. So this almost coincides with what we want as psychiatrists. We want effectiveness, not the efficacy of the textbooks. No residual symptoms. Sometimes these residual symptoms, proletariat practitioners like me, the residual symptoms keep on bugging us continuously. safety and tolerability as usual, minimal drug reactions, lasting therapeutic effect, and in bipolar disorder, possibly a cognitive improvement. Cognitive improvement in bipolar disorder. There has recently been a scale called COBRA, which has been published by the ISPD. So cognitive improvement goes a long way in ensuring treatment adherence and, other positive aspects of bipolar disorder. Real world, we don't have, as I was telling, the binary concept. What we have over here is the Australian group's introduction of the ACE concept or the ACE concept, where they have mapped attention, cognition, and emotion along the course of bipolar disorder. And if you tease out the DSM-5 symptoms, you'll find that all these three components are present. While the DSM-5 had actually focused only on activity and mood, in order to treat a person properly in real life, possibly the ACE model is much more helpful. Again, the stratified model, when we are treating the person, we should treat the person and not the illness. The core, that is what we usually treat and then stop treating. The personality disorders, the comorbidities, how these comorbidities are actually influencing the core psychopathology, any other physical illness, and the context of treatment, those social support, age, pregnancy, etc. All these things are very important in bipolar psychopharmacology. There are various mechanisms in bipolar, how the bipolar medicines work, and, myriad of mechanisms. No single transmitter is effective for bipolar disorder or is responsible for bipolar disorder. And a lot of genomic studies are now taking place, gearing us towards personalized psychiatry and precision psychiatry in bipolar disorders. So one of this is this, what we have is the protein kinase C. What we are going to discuss, what we have been discussing today mostly revolves around protein kinase C. In mania, as we know, protein kinase C is increased. Now, protein kinase C is reduced both by lithium and divalproate, both in vitro and in vivo. Protein kinase C inhibitors, tamoxifen, endoxifen, actually reduce mania. And there's also a reduction in manic symptoms by, protein kinase C inhibitors. So this actually gives rise to the euthymic mode. So is protein kinase C the ever first proper therapeutic target in this quagmire of bipolar disorder? The targets are validation. This was actually proposed by Hussein Imanji and Carlos Zarate. So validation, the criteria the target should be valid or similarly functional both at the protein level and the molecular level. Observation, as you see, the lithium and sodium valproate, lithium being an anionic metal in what is happening, and sodium valproate, sometimes an acid, both chemically completely dissimilar, but both of them have been inhibiting protein kinase. Consistency between therapeutic effects and plasma level, relevance to no illness pathology, location to brain regions implicated in the region. So this PKC is primarily condensed in the frontal limbic cortex, prefrontal cortex, hippocampus, amygdala, and this is the region which is primarily involved in bipolar disorder. Temporality, quicker therapeutic onset, and possibly a lasting effect. So as I have, this is a slide telling you about how lithium and sodium valproate actually reduces this. All these papers have already been discussed by my previous speakers, especially Professor Andrade. Notably, what is important is this, the difference in the therapeutics, in the side effects. This is something which is very much important. And as you see, whatever be the methodology of this study, endoxifen has been almost at par with divalproic sodium concerning reduction in illness severity, MADRS score, and a lot of other parameters. Similarly, in YMRS also, they are hardly separating from each other. The second study also has been discussed, and here you find the change in the baseline. This is the 8 milligram dose, this is the 4 milligram dose, so this is the valproate, and this is the 4 milligram dose. So there has been significant change in the reduction in YMRS. Not only that, the change with 8 milligram and 4 milligram doses of endoxifen has been perceived always and quite early, as early as day 4. Adverse effects. Endoxifen doesn't have any metabolic adverse effects except for possible triglyceridemia, but it doesn't need a rescue medicine. Unlike sodium valproate, unlike lithium, unlike the others, it is possibly, probably helpful in suicidal behavior, anecdotal reports, and it doesn't cause treatment emergent depression. Here you can find why are we not talking about tamoxifen and why about endoxifen? Look at the extent to which endoxifen actually inhibits protein kinase C, almost 4 times as much as tamoxifen. And so if PKC is a significant target in bipolar disorder, why not deal with it directly, and why not by the best addresser? So concluding, endoxifen is definitely a superior candidate for bipolar disorder, especially acute mania and mixed episodes. We still don't have any study on depression. Again, in these bipolar 1 disorders, especially in patients with defective activating enzymes of tamoxifen metabolism, endoxifen dose, as Dr. Jhawar was hinting at, may need to be increased in males than in females on a weight-to-weight basis. It can be used both as monotherapy and adjuvant. It is probably the first antimanic agent which is trying to address personalized psychiatry and precision psychiatry. I would say quicker onset of action from my personal experience. Multimodal action. We still have we are probably seeing the tip of the iceberg with endoxifen. There's still a lot more to come. Safety and tolerability, as I had already told you. Anti-suicidal, possibly does, pro-cognitive, possibly the best antimanic for residual symptoms. So I have a small request to my next speaker, an encouraging request. He can actually formulate his presentation with these few questions. That is, which antimanic molecule has greater efficacy and tolerability than endoxifen? Among lithium divalproics and endoxifen, which is the safest antimanic in consultation liaison psychiatry? Why should protein kinase C not be considered as the first mechanistically distinct target in bipolar disorders? And among lithium divalproics and endoxifen, which is the best option for personalized and precision psychiatry? Which antimanic agent is being studied to possibly reduce bipolar disorder susceptibility in bipolar probands? there are various. So what I wanted to say is that if endoxifen is not the present of real world psychiatry, psychiatry will have no future present. And there are studies and other studies, as I was talking about this Eli Lilly and Zyprexa. So you have to take every study with a grain of salt, not using, find out whether the study is using anything like this weight machine. Thank you.
Thank you, Devashish. I like the tagline of endoxifen with a personalized or precision psychiatry. I liked the open challenge that you have thrown to Dr. Avinash D'Souza with a host of difficult real world sawal or questions. And over to you, Avinash, for answering those questions which appeared in the penultimate slide. Avinash, over to you.
Yeah, 1 minute, so I'll just share my screen. Okay, good evening, everyone, and thank you to Banai for having me here. And a very big thank you to Dr. Devashish for his questions. Dr. Devashish is a very good friend, but at the same time, today we are pitted against each other. Well, to talk about endoxifen, I will start with something which Dr. Devashish said, and I think he made a statement that we've reached a stage where we're frustrated with the psychopharmacology of bipolar. I don't think so. I think we pretty well manage our patients. We sort of manage them with the right combinations. Dr. Kesavan said that in India, we prefer using an atypical antipsychotic combination with a mood stabilizer. And over the years, I think we've been fairly successful in managing our patients with bipolar disorder. So I think frustration definitely is not something which is there. He also mentioned that a lot of our prescriptions and a lot of our thoughts are pharmaceutical driven, which definitely was pretty well reflected over there. But at the same time, I think we're also experience driven. So to answer my first question is, to answer some of the things which he has said, and I'm going to add some points of my own, is he said we have a huge patient load. And my, first sort of question there is, how many patients do we have on divalproex? How many patients do we have on lithium? How many patients do we have on oxcarbazepine? Well, quite a lot. How many patients do we have on endoxifen? And I think even Dr. Devashish would agree, few. So while we say that endoxifen is a monotherapy, like you mentioned towards the end of your presentation, I would definitely want to know how many patients of endoxifen do you have on monotherapy in your clinic, and what are the results? Whereas vis-a-vis, how many patients with lithium monotherapy, divalproex monotherapy, or carbamazepine, oxcarbazepine monotherapy you treated? I think definitely, without even thinking or blinking, the numbers are far more. Well, you mentioned about functional recovery, and that's very important. And I would like to start with a slight disclaimer here that what I'm presenting here, well, clinically, I would like to use endoxifen and see how we are, but I'm presenting here for the sake of the debate. So I'm a lawyer here today, and my arguments aren't personal, they are purely professional because I have to argue. If you look at bipolar disorder, and I think even Devashish mentioned, we have so many mechanisms. So why are we focusing on one small isoenzyme called PKC when we have brain changes, neurotransmitters, environmental factors, psychotherapy that has to be an add-on, behavioral changes. We have to look at mood stabilization. PKC plays a role in almost many other psychiatric disorders also. Why are we focusing so much on PKC here? And yes, as you mentioned, in bipolar disorder, we have multiple circuitry which are there. So we are focusing on a cellular mechanism, something that we can't see, we don't know. Whereas with lithium over the years, we've used it, we've tried it. We know how effective it is. In the middle of the night, I could prescribe lithium because I know how to use it. I know the safety aspects. I know the tolerability aspects. I know the monitoring aspects. Same goes with divalproex and multiple other drugs versus endoxifen, where our experience is limited. Number of studies were mentioned by our speakers, as well as Debashish mentioned a few studies. Guidelines for bipolar. There are so many guidelines. Where does endoxifen figure in those guidelines? Nowhere so far, because yes, your argument would be the drug is new. My simple question, in your family that develops any illness, are you going to a doctor with 30 years experience, or are you going to go to a doctor with a few months of experience? The answer is 30 years of experience, lot of experience. The same holds true when we prescribe lithium, divalproex, because we've used them over the years, right from our residency days to 2-3 decades of practice. Endoxifen has come now. We don't know how it will go. Even I can't comment about it. But right now, to say it's the best drug, the new kid on the block, the best thing that's ever happened to bipolar disorder, no, I have my reservations there. Endoxifen belongs to a class of drugs which are known as selective estrogen receptor modulators. And believe me, estrogen receptor modulators are drugs which don't only work on the brain, they also work on the body. They work on the bone, the liver, the breast, multiple areas. Amongst these, we have tamoxifen, endoxifen, amrolifexin, we have raloxifen. Raloxifen has been used in some trials in schizophrenia with very little success. Endoxifen and bipolar, tolerability-wise, it has some advantages, maybe, but efficacy-wise, it's the same as divalproex. When you need a drug in bipolar disorder, your points were, you need a drug where relapse doesn't happen. What is the rate of relapse with endoxifen? Do you have an answer? We don't. What is the rate of relapse with lithium? It's quite less. Yes, it does happen. Relapse, I don't deny that, but quite less. What is the rate of relapse with divalproex? Quite less again. With endoxifen, we don't have an answer. It's wrong to say relapses happen. We don't have an answer, so we can't comment. You mentioned it has to be cost effective, and that's where is my main crux. What is the cost of lithium? 1 year's therapy versus 1 month's therapy of endoxifen. X cost versus the cost of endoxifen. Also, when it comes to cognitive impairment, I think whether you look at patients with lithium, divalproex, yes, cognitive changes occur in bipolar disorder even as a result of the disorder itself. It's wrong to blame the drug. And does endoxifen prevent cognitive impairment? Are there studies? We don't know. So endoxifen was developed as an anti-cancer agent initially. But now we're using it in bipolar disorder. It has its own effects on the breast, on the bone, on the liver. So while we may cause this precision pharmacotherapy to happen, would we also cause feminization in our patients? We don't know. So it makes you think, should I use endoxifen? Should I not use it? Endoxifen, you spoke about 4 milligrams and 8 milligrams. I would love to know whether divalproex was used in doses above 1,000 milligram in those studies. And I don't think we have data. If it was probably used at 1,500 milligrams, the 8 mg graph and the 1,500 mg graph of divalproex would have probably been at the same level. So to answer your questions, do I have a drug which is more tolerable than endoxifen, better compared to lithium divalproex where there are so many side effects? My answer here is, how many patients have we given lithium and divalproex to? I think the number would be in 3 figures, 3 digits, 4 digits. And side effect profiles we are aware of and we know how to monitor. With endoxifen, we have no idea. Which is the most efficacious drug when it comes to consultation liaison psychiatry and the use of drugs used in bipolar disorder? Time and again, we have used valproate, carbamazepine, lamotrigine, multiple of these drugs. Endoxifen, have we used it? Are there studies? No, it's a new drug. I'm not saying why they aren't studies, but they aren't. Is protein kinase C the best substrate? Is it a very specific substrate? You yourself have mentioned that lithium and divalproex also inhibit it. So then why do we need endoxifen to specifically come and say, I'm inhibiting it? We have somebody who can cook for us, wash our clothes, clean the house. Why do we need someone specific only to wash the clothes? No, we don't. The genetic aspect, you spoke about pro-bands and genetic medicine. Have we reached there? No. Will we reach there in the future? I don't know. We are there. We were going there slowly. When we reach there, we look at it. What is the best option when it comes to managing bipolar disorder? Endoxifen. This is the look I'll give you if you talk to me about endoxifen. Because I don't know. I haven't used it. There are others here who may have used it, but have you used it as much as lithium, as much as divalproex, to put your money on it? I don't think. There are studies, there are trials, there are multiple things. Yes, studies, you have a placebo arm. We don't have head-on studies of lithium against endoxifen to say anything. So, to end, I would want to say, being entirely honest with oneself is a good exercise. I would be honest to say I have so many things against endoxifen. I have not used it. So if you tell me, can you say for sure that you're against endoxifen and can you say for sure it's efficacious? I think Debashish should also agree that we haven't used it as much as we've used lithium or divalproex. So we really can't say. But if I had to vouch for lithium, and yes, I had to put my money on it, I would. If I had to vouch for divalproex, I would. My last words. In the small matters, trust the mind. In the large ones, trust the heart. So, when it comes to precision medicine, state-of-the-art psychiatry, trust the mind. You want to go with endoxifen and treat the classes, it's your choice. But large ones, when it comes to treating the masses, it's always been lithium and divalproex. Thank you.
Thank you, Avinash, for a very combative presentation. Certainly a very thought-provoking, interesting presentation. I would now request Dr. Debashish to present a counterpoint. And Avinash, you present one after this.
Many thanks, Avinash, for conceding that endoxifen is superior to valproate in concerning safety and tolerability, and also you said that endoxifen is equivalent to valproate in efficacy. You have made my Sunday one. When I was talking about the frustration in bipolar psychopharmacology, I was talking about a concept which was floated by Nasir Ghaemi, that when we practice, because of the we do not do psychiatry. At least I believe I do not do psychiatry. What I do is what Nasir Ghaemi had called med checking. And pure med checking doesn't subserve real world psychiatry. So probably I have been misunderstood. I have to brush my English further. Thanks for reminding me that. Similarly, the second thing that you have said is again a misunderstood context. Patient load. I had never said that, patient load is more with endoxifen. What I said with our patient load, if you see around 60 to 80 patients in 4 hours, it is difficult to practice proper real world psychiatry. So you have always been talking about, 40 studies, 50 studies. I believe you didn't go to school the day you're born. You have conceded that endoxifen is a new kid in town. It is a new kid in town. I am not telling that endoxifen is a panacea for all bipolar disorders. My understanding of bipolar disorder is still very, very, very unclear. And if you're talking about cellular mechanisms only and extracellular mechanisms, or why we should not be concerned about PKC, if the moderator allows, I can share some slides.
Certainly do, sir. We have all the time in the world to hear and understand and learn.
And I am having some hassles in sharing the slides again. I don't know.
Zishan can assist you, but we are all eyes and ears, I can assure you.
Okay, right. Let me see. Actually, I couldn't present my slides properly. This was a different thing. Oh no. Can you see any slide?
We can see lots of slides and all interesting slides.
Okay. So, we have these protein kinase C subfamilies, and the protein kinase C alpha, beta, and gamma. They are mostly condensed in this frontal limbic region. And what they do is they work in different stages. In the short term, they affect the neurotransmitter release. In the medium term, they cause a receptor regulation. And in the long term, cell proliferation, synaptic remodeling, and gene expression. So, we are probably going to the first what we call multimodal treatment of bipolar, maybe mania. When lithium had come in Australia, serendipitously, probably if we go by your logic, we would still be using chlorpromazine in erectile dysfunction because of the ancient the dynastic sort of the primary antipsychotic. So just because a molecule is new, there is no reason to believe that this molecule will have lesser side effects than valproate or others. It has been proved in 2 studies, I admit, which need correction, but it has been proved that 8 milligram doses of endoxifen was you have told already, I'm really impressed that one study takes that statement out of your lips that endoxifen is, superior to, valproate in terms of safety and tolerability. Endoxifen is superior to, is equivalent in cases of efficacy. Concerning this heritability, bipolar heritability, you said that we are far away from that. May not be. Studies have already been on, and some studies have already implicated PKC zeta, another subfraction of PKC, which is involved in, once you suppress PKC zeta, there's a reduction in the heritability in bipolar probands. We have newer open vistas for endoxifen. Okay, so we have a molecule in hand. Bipolar depression, we hardly understand properly, completely. Bipolar disorder, bipolar mania, we hardly understand, leave alone treat it properly. And in my personal experience, I have, my patients have been very, very satisfied with endoxifen, even monotherapy. And in acute mania, you need the loading dose of sodium valproate. Again, you say a new kid in town, maybe we are going to, endoxifen is going to have new dresses, I'm sure. Don't worry. Thank you.
Thank you, Devashish. Thank you once again for a very honest to God presentation. The floor is yours now, Avinash.
Well, I think while Debashish and I are pretty much very close as friends. Is there some noise?
Your voice is
Dr.
echoing.
Mittal will have
to mute, please.
Dr. Mittal will have to mute.
Oh.
Yeah. So while we're here to debate on endoxifen, I think since I have like the last word in this debate, yes, I agree with Debashish on multiple counts. If I don't agree with him, I probably won't be allowed after the pandemic in Kolkata. So I have to agree with him on certain counts. But the thing is, I will definitely say that yes, endoxifen is the new kid on the block. We have used it sparingly. We need to look at it more carefully. I mentioned points against endoxifen. Like I said, it was not more out of personal grudge against it. It was more for the debate. But I think one of the things which we all will take home from this seminar is that we got to look at how endoxifen would work in the long term. The cost is one aspect which will have to be worked out for many of our patients. That is one. The second thing which I feel is I would love to see how it works in combination with other mood stabilizers. So endoxifen combined with divalproex or lithium, particularly when we're really looking at multimodal, I would put it that way, wherein, endoxifen being multimodal itself and combining it with multimodal drugs like, say, lithium or, divalproex or lamotrigine and, whether a lamotrigine endoxifen combination would work very well. Those are things which I would, probably time would tell us. Maybe 2022 end, when we come back after a year of experience with endoxifen, we would be in a better position to, talk about how we feel personally with the drug. It would also be very beautiful to see if endoxifen shows superior efficacy in female patients with bipolar disorder, considering its estrogen selectivity. And that's something which I think studies over time will probably tell us. It would also be interesting to see whether when we look at acute mania, yes, efficacy of endoxifen is something which over time will only probably be in a better position to tell us whether the only one thing is that I think from a clinical perspective is that the studies on endoxifen have mentioned insomnia as a side effect in some patients. And I think in acute mania, we would want the patient to sleep because lack of sleep is one thing which is an issue that comes up. So I think there we would have to look at. But nevertheless, yes, I think endoxifen is a new drug. We have to use it. We have to try it. And over time, probably we'll then be in a better position to see how it is. And maybe, yes, a year from now, Debashish and I will laugh about this debate and talk about our experience on endoxifen. Thank you.
Thank you both speakers. Thank you both of the debaters. It's been very enlightening and it's been a nice counterpoint repartee. Now I move on to the last part of the program, the most interesting part, where we have a host of prizes, and we have none other than Dr. Anukant Mittal to host this program. This program consists of three parts or two parts. One is a quiz and second is the question answer session. We have lots of time at hand, and Dr. Anukant Mittal, the floor is to you. Floor is open to you, sir.
Good evening, everybody. I know I'm standing between you and dinner, but also I'm standing between you and a few $1,000 to earn. There are three important things Dr. Nagpal missed out on. One is a constructive critique or a summary by somebody. The second, before that, we would have a quiz then a constructive critique, and then we'll have the question and answers to be answered by the respective speakers. And we would have prizes. The best question that would have a prize of Amazon voucher of 5,000 rupees. The quiz has the fastest finger right answers. 3 prizes. The first prize is a voucher of 5,000. The second of 3,000, and the third of 2,000 Amazon vouchers. And of course, there is a prize for the constructive critique. So can we now start with the quiz? The quiz works very simply. The question would be put up. I would read the question. I would then ask the timer to be started. You would have 10 seconds to write your answer in the chat. And at the end of 10 seconds, I would give you the answer and move on to the next question. There are 10 such questions. My backend team would be working on your answers off the chat on who's the fastest and who's the right, and they would total up. And then during the question and answer hours, they would probably give me the results, and I would then declare the winners. So let me start by passing a few comments of my own, saying very well said, both the debates and all the 4 speakers. Excellent presentations. We've had a comprehensive review of as everybody keeps calling it, new kid on the block. I remember when I came back from UK, the first second generation antipsychotic came with me, as did sertraline. So I came to India from UK with olanzapine and sertraline in tow. And olanzapine was a new kid on the block. But within a year, it had kind of replaced almost 90% of the prescriptions of the conventional antipsychotics. The same thing, I think, happened with SSRIs. Within a couple of years of fluoxetine and sertraline coming onto the market, the older tricyclics kind of just faded away into a minimalistic background. Provided endoxifen proves itself in the market. And the best proof, as we say, the proof of the pudding is in the eating. So we give it to our patients, as Dr. Debashish said, as monotherapy, or as Dr. Avinash, Dr. Venu said, as adjunctive therapy, or as additional therapy, as polytherapy, and we see the effectiveness of the drug, and time will tell us how it works. So I now start with the quiz. If we are all ready, is the backend team ready with the quiz questions? Can we have the first quiz question, please?
Yes, sir.
Yeah. Can we please put it on?
One second, sir.
Yeah, sure. Question 1. What are the 3 classes of protein C kinase isoenzymes? If can we start the clock now, please? 10 seconds. So if you've seen Dr. Debashish's slide, which he's shown 3 times, you would be able to answer this well. Thank you. Could you stop the clock? Or you're going to go on?
Shall we display the answer, sir?
Yeah, please. Okay. Classical, conventional, and atypical classes are the 3 classes of protein C kinase. Okay. Next, please. Question number 2. Please go into your chat box and answer. Name 2 neurotransmitters that activate PKC. Name the 2 neurotransmitters. Start now, please. The time, please. Start from 10. Yeah. Okay. Get into the chat box. Fastest finger first. who can type well. Thank you. Can we have the answer, please? No. Yeah. Dopamine and endorphins. They are the right answer. Next, please. Question 3. Is the inhibition of protein kinase C by endoxifen dose dependent? That means, does the inhibition change and depend only on the dose? So if you increase or decrease the endoxifen dose, does the inhibition change? Start now, please. Yes, 10. So you would have to look at the graphs which are shown by Dr. Keswan. Yeah, thank you very much. Can we have the answer, please? Yes, it is a dose-dependent curve that Dr. Keswan showed. Next, please. Question number 4. What is the indirect protein kinase C inhibition mechanism in bipolar disorder? If you remember, again, this is based on Dr. Keswan's reports and partly on Dr. Debashish Rai's slides. Start now, please. Yep, 10. Right. Okay. Let's see what the response is. Yes, please. Can we have the answer? Inositol depletion mechanism or the hypothesis of the depletion mechanism. Yeah. Thank you, please. Next question, 5. How long does it take endoxifen to reach its steady state concentration? This is talking more about pharmacokinetics. Start the count now, please. So we talked about the time it takes to act and the time to see the beneficial effects. Can we have the answer, please? 14 days, right? So this, next please. Commonest benign side effects seen with endoxifen in most of the studies that were presented by 3 different presenters to you today. I'm sure by now you would have an idea of that. Can we start the clock now, please? Yep. Okay. So which is the commonest benign side effect, which makes it easier to use and safer? Next, please. Dyspepsia, right? Okay. So question number 7, please. What class of drug is endoxifen? Now that is the most simple one. If you have watched slide 1 of Dr. Chitranjan Nandarade and slides thereon, you would know what class of drugs it is. Start the clock, please. It's one of the easiest answers, I suppose, and you should have answered. Most of you should have answered by now, right? Okay, so thank you. Can we have the answer, please? Yeah. Selective estrogen receptor modulator. Right. Next, please. Question 8. Which common side effect of divalproex is not seen with endoxifen? Can we start with the clock, please? So this is the advantage that endoxifen has over divalproate, which makes it a safer and a better choice probably in prescription. Next answer, please. Hair loss, which is one of the commonest but very disturbing for young population, especially females and males. Next, please. Question 9, please. Which common side effect of lithium is not seen with endoxifen? So we start the clock now, please. Right. So again, extolling the virtues of endoxifen of having lesser side effects or lesser disturbances than established drugs like lithium and valproate. Can we stop the clock, please, and have the answer? Tremors, which are very disturbing and disabling for patients who are on lithium for a long period of time. Next, the last question, please. What is the half-life of endoxifen? That is, how long does it take for it to get metabolized in the body to the extent of 50%. So start now clock now, please. Right. Okay. I think that's sufficient time. Can we have approximately 50 hours, which is quite a long time. So, right, we end here. And can we have somebody in the back office start working on the results at ease? I would like to now probably start with the questions. Do we have the speakers there? The first question is from Dr. Prashant Sunil Chaudhary. Since there are multiple mechanisms for lithium in mania, does success of endoxifen point towards specific molecular mechanism for pathophysiology of mania? I think this goes to Dr. Chitranjan, Dr. Keshwan. Any who would like to answer, please?
Okay, I can give it a shot. Chitranjan Andrade here.
Yeah, so we can recognize, Chitu, we can recognize your voice. Yes, please. Yeah, please. Please go ahead.
Antidepressant drugs, for example, can act through serotonin, dopamine, and norepinephrine. Antidepressant drugs like ketamine can act through NMDA receptors. So there are multiple routes towards efficacy. So just because PKC is one route doesn't mean that it is the only route. There could be other routes also towards anti-manic efficacy, including, for example, an increasing stability of neuronal membranes produced by, say, the anticonvulsant drugs. Nothing to do with PKC at all. Right? So I hope that answers the question.
Yeah. Okay. Anybody else would like to add to that? Okay, we go to the next one. Next question is by Dr. Vikrant Mittal. Is the incidence of DVT due to endoxifen same in male and females?
I will answer the question because I raised the issue. Chitranjan Andrade here again. The answer is we don't know. Simply because tamoxifen and endoxifen have been very, very extensively used in women. For example, for the treatment of estrogen receptor sensitive breast cancer. But the use in men has been very, very small, such as for anti-androgen dependent gynecomastia in men being treated for prostate cancer. So we don't have the same amount of data in men as in women. Having said so, I see no reason why there should be much difference, because after all, the mechanism is the same. Whether it is in men or in women, the mechanism is the same.
For the DVT.
Through estrogen receptors. Yes.
Right. Thank you. Thank you, Dr. Andrade. The next question is Dr. Shobit Garg. Study by Ahmad et al. Also due to high sample size may have spurious higher effect size. Remission is a product of clinical improvement for a duration of period, like in BPAD, it is 2 months. So it's inappropriate to comment on early. Is it inappropriate to comment on early remission?
I'm assuming that that question is also directed to me.
Yeah, it looks like that. Yes, it is.
One is with regard to the sample size. The larger the sample size, the more reliable or the more trustworthy the results of the study. So that's not a criticism of the study. That's actually an asset of the study.
Yeah.
Having said so, coming to the second part of the question about remission occurring within 2 days or 4 days, actually, if you recall, I said that the statistical analyses for both of the Ahmed studies were not good. And one of the reasons for this was both studies presented within group changes.
Changes.
So, in some patients, maybe because they were ending their natural course of mania, they remitted early. So, just because one patient remitted in 2 days or 4 days, or say 2 patients remitted in 2 days or 4 days, doesn't mean that remission starts early with endoxifen or with valproate. Keep in mind also that the recovery curves for endoxifen and valproate were almost identical. The two lines overlap to such a great extent that you could hardly see any difference between the recovery curves. So if you're saying that patients respond or remit very quickly with endoxifen, you should also say in the same breath that patients respond and remit very quickly with valproate, because the curves were almost superimposed on each other. And we know that valproate doesn't work miracles. So if valproate doesn't work miracles, neither does endoxifen. It was an artifact of the method of statistical analysis.
Yeah. Okay. Now this is Prashant Chaudhary again. Can endoxifen be used as monotherapy in the ongoing episode of mania? Well, I think Dr. Venugopal Jhawar, Dr. Keshwan, and Dr. Debashish, all three who are actually talking about using it as monotherapy or have done extensive studies with it, could talk about it. Or Dr. Andrade, what do you think?
If you were to ask me, I would say that if you go by the clinical trials, both the Ahmed studies found that monotherapy was associated with a 50% response rate at week 3 and with a 33% remission rate at week 3 with no add-ons, no convex. That is, no patient received rescue haloperidol or risperidone, or no patient, or almost no patients required SOS treatment with lorazepam or with diazepam. So both valproate and endoxifen in monotherapy seem to have worked miraculously in the samples studied by Ahmed et al. If you take these studies at their face value, then yes, endoxifen can be used as monotherapy for the treatment of mania, and valproate can also be used as monotherapy for the treatment of mania. In practice, we don't see this happening. The more severe the mania, the more likely it is that patients will require concurrent medications in addition to a mood stabilizer. So there is a disconnect between theory and practice over here, the clinical trial and practice.
Even the guidelines mention use of multiple therapy, a mood stabilizer, an antipsychotic, or whatever. Dr. Upasna has asked, what was the rationale behind trying out endoxifen in gaming disorder? Have protein kinase inhibitors been tried on behavior addiction previously? This was directed at Dr. Venugopal. Is he there?
No, he's not there. He's left.
Okay. Has anybody else used endoxifen in gaming disorder? Because this was a question posed by him in his presentation. Okay, we'll move on to the next. Dr. Vikrant Pittal. Is there a difference between side effect EPS between 4 milligram and 8 milligram? Was that compared, Dr. Andrade, between in the Ahmad study?
In the study, 4 milligrams numerically performed worse than 8 milligrams. But there was no statistical comparison between the two groups. I suspect that had statistical comparison been done, the study would not have found a difference, but this is because it was underpowered to compare 4 mg versus 8 mg.
True. Okay. Dr. Prashant Chaudhary has asked again, the question is different. Endoxifen having action at the third messenger system. If studies could conclusively prove the efficacy in all types of bipolar disorders, would then that be a step towards finding common neurobiological substrate for the phenomenologically distinct variants? Dr. Andrade, this is quite a
My answer remains the same.
Yes, there are various pathways and various ways that we get the phenotype. So maybe, maybe not. Let's see. Dr. Shobit Garg, if QTP is quetiapine is bimodal as per CanMat, then why not olanzapine is bimodal except metabolic side effects? Is there anybody who can answer that?
Yeah, maybe I can answer that.
Yeah. Yes, please.
Yeah, I think that's a good question because one of the drugs that was said to be as bimodal as quetiapine was olanzapine. And I did not touch upon it in my presentation because it's now been downgraded to a second line drug, simply because long-term use with olanzapine predisposes to metabolic side effects, and quite serious ones at that. But if you look at the evidence for the use of quetiapine, olanzapine and bipolar disorder and acute mania, there are about 4 or 5 trials, both olanzapine monotherapy and olanzapine in combination with valproate that have been found to be efficacious in treating acute mania. In terms of treating bipolar depression, the evidence is not as strong. There is evidence for, we all know that famous study where olanzapine fluoxetine combination was tried in comparison with olanzapine and placebo in the treatment of acute bipolar depression. And olanzapine plus fluoxetine had superior efficacy than olanzapine and placebo.
Placebo, yeah, true.
One of the criticisms of that study is that there was no separate fluoxetine arm, which was
independent fluoxetine arm. Yeah.
Yes, whether the extra benefit that we see is solely because of fluoxetine and whether there is actually adequate benefit. Apart from another study that has also looked at olanzapine fluoxetine combination versus lamotrigine and found to have superior efficacy compared to lamotrigine. Apart from these, there are no other studies that have actually looked at whether olanzapine is efficacious in acute bipolar depression. So in terms of the evidence for the use of olanzapine as a bimodal agent, the evidence for in bipolar depression is very limited compared to its efficacy in mania. And I think that's why, we probably can't call it as bimodal a drug as quetiapine.
Yeah.
Thank you.
Dr. Jiten, thank you very much, sir. Dr. Jitendra Nanawala from Gujarat is asking, Dr. Debashish Rai, are you there?
Yes.
I don't think this is a question relevant. Can you elaborate on poor political situations? I'm sorry, I shouldn't have asked this question. Yeah. Dr. Nanawala, can we confine ourselves to the topic at hand, please? His next question is, can we combine endoxifen in patients who are not well responding to lithium plus sodium valproate plus second generation antipsychotic? So he's using a cocktail of lithium plus valproate plus second generation antipsychotic. And wants to ask if you can combine endoxifen to this cocktail of 3 drugs. Any rationale, any study, any Dr. Keshwan, Dr. Debashish, anybody?
I am not aware of any study like this.
To me, it appears like you're looking at treatment-resistant bipolar if somebody needs so many drugs. And I'm not sure if endoxifen has been studied in treatment-resistant bipolar. So
we probably need to begin and start first with re-evaluating the diagnosis and probably look at the dosages. Okay. Next question is Dr. Manish Gupta asking Dr. Andrade. How is it possible that patient with average young mania rating scale score of 33 did not need any antipsychotic for 3 weeks in a trial? Would you say this is a major confounding factor in generalizing the results of phase 3 trial to real practice?
So I had red flagged that concern in my slides as a limitation of the studies.
True.
With just 1 gram of valproate a day, we don't see patients with severe mania responding to a rate of 50% and remitting to a rate of 33% in a period of 3 weeks.
3 weeks.
This
True.
is what Dr. Nagpal also pointed out in his opening question to me.
True.
Are we comparing escitalopram with 75 milligrams of venlafaxine?
That's venlafaxine. True.
Yes, so endoxifen being compared with 1 gram of valproate suggests that valproate was being underdosed, and if underdosing valproate is also associated with magnificent results in a clinical trial, it suggests that the clinical trial was conducted atypically.
Right, or it would stand our whole concept of the dosage of valproate on its head and say that we are overdosing our patients. Okay. Thank you, Dr. Andrade. Dr. Johnson has asked, is endoxifen useful in bipolar depression and rapid cycling? Now, the studies, I don't remember any of rapid cycling.
Nobody can answer that question because there are no studies. It has not been studied. All the trials on tamoxifen and endoxifen have only been conducted in mania.
Dr. Johnson again asked, does it have a role in substance comorbidity? Again, there is no study, particularly comparing patients with comorbid substance and no comorbid substance. Dr. Ganesh Shankar, since tamoxifen got uterine endometrial hyperplasia, is there any new need for regular monitoring for female patients treated with endoxifen when an active metabolite, which is an active metabolite of tamoxifen? Is there any need for regular monitoring for female patients?
If you're going to be prescribing tamoxifen or endoxifen for years, the answer is yes. But anyway, some monitoring, for example, for cervical cancer, pap smears and so on, is recommended for women.
Right. Okay. Dr. Nishan Shah is asking how to start endoxifen. Initial blood or CVS workup needed or not? Well, Dr. Devashish Rai, Dr. Keswan.
I don't think Anukant, you're saying something.
Yeah, Devashish, Dr. Nishan Shah is asking.
Yes.
That before starting endoxifen, do you do any initial blood work or cardiac work?
I don't think there's any evidence towards that, and we do not do anything like that. You know, maybe what is necessary, especially in women, even when you're giving it for 6 months or less, is to gradually monitor whether there has been any new breast lump or monitor for DVT.
Okay.
But pre-workup, nothing.
Okay. Thank you. Dr. Manmeet Kaur, is there evidence for endoxifen use beyond 3 weeks? I mean, she means apart from the AMA trials, is there any other evidence of long-term use of endoxifen? I think it has been
no use, which is why in my summary slide I mentioned that long-term maintenance therapy trials are now required.
Yeah, probably there is no evidence, but we have amongst our clinicians who have been using it for more than 3 weeks. Dr. Debashish, Dr. Keshwan, Dr. Venugopal, Dr.
I'm not aware of any study.
No, but in your experience, have you used it for more than 3 weeks?
Yes, definitely. Without any side effects.
Okay.
Primarily in mixed bipolar.
Right. So probably what we are looking, Dr. Kaur, is that since it's a new drug on the block, there is still, people are starting to use it. There are still studies underway. Probably we will in a year's time get 6 months study follow-up, 1 year follow-up studies, etc. Dr. Gyanendra Verma, can endoxifen can be given to pregnant or lactating patients? I think Dr. Chitranjan Andrade answered that in his presentation, didn't you, sir?
Yes, the answer is no. It is contraindicated in pregnancy and it is not recommended during lactation.
True.
It is contraindicated in pregnancy because tamoxifen has been associated with an 18% risk of major congenital malformations, and not recommended during lactation because it is excreted into breast milk and it accumulates in breast milk.
Yeah, true. You mentioned that in your presentation, right? Okay, I'll take a short respite for you. We can announce the winners of the quiz. The fastest finger with the largest score, the winner of the 5,000 rupee Amazon voucher is Dr. Roshan. The first runner-up is Dr. Ved Singh, who gets a 3,000 rupee Amazon voucher, and Dr. Tanu, who is the second runner-up, who gets a 2,000 rupee Amazon voucher. Can you, you obviously have been on the chat, so probably my backend team would get in touch with you and would liaise with you to send you the vouchers in your WhatsApp or whatever. So congratulations, that is excellent, and we'll probably try to get you the statistics at the end. Question number 18, Dr. Tanu. Role of clozapine versus endoxifen in delirium and EPS caused by polypharmacy. I wouldn't be aware of any study or any documentation done. Are you aware, Dr. Andrade?
None.
There is no study or any evidence at all, ma'am. Dr. Mayur Muthe, can we continue with endoxifen beyond that 3 weeks? I think that has already been answered. There is no evidence of long-term follow-up, but clinically there are colleagues who are using it. Dr. Manmeet Kaur has asked, has endoxifen been used in breast cancer treatment? If yes, then what dose, and do we know the estrogen effects in long-term use? Also, what is the difference between estrogen effect of 8 milligram versus tamoxifen in the usual dose of 20 to 40 milligram and even higher doses? I would put this ball in definitely Dr. Andrade's court.
Okay, with regard to the first part of the question, the use of endoxifen for breast cancer for estrogen receptor positive breast cancer patients. The answer is nobody's going to prescribe endoxifen when tamoxifen is out of patent and tamoxifen costs next to nothing. Yeah. So the answer is no. It's tamoxifen which is being used, and tamoxifen is being used with the proviso that patients should not be receiving a concomitant 2D6 inhibitor along with the treatment. The second part of the question was what?
Difference between estrogen effect of 8 milligram endoxifen versus tamoxifen.
Yes, endoxifen is supposed to be more potent an inhibitor than tamoxifen, but the studies which I have seen don't comment whether this is mg per mg or therapeutic dose for therapeutic dose.
Okay. So no evidence of that?
So we don't know the answer to the second part of the question.
We have the last 2-3 questions left. If you would bear with me, Dr. Gyanendra Verma has asked, is it good to prescribe endoxifen for long-term management in female patients? I think that's already been answered, but if Dr. Andrade would give a one-liner for it.
As far as research evidence is concerned, we don't know the answer because the studies are yet to be conducted. As far as clinical or, on theoretical grounds, I see no reason why endoxifen cannot be continued in the long run, if only because tamoxifen is routinely prescribed for 5 years.
5 years, yeah.
And a Lancet study suggested that benefits continue even if tamoxifen is prescribed for 10 years.
Right. Okay. Right. Dr. Tanu has asked, is there any difference between bimodal drugs and mood stabilizers?
I think I had mentioned it in one of my slides. So bimodal drugs, we are looking at drugs that can treat acute episodes of mania and depression, whereas a mood stabilizer also refers to the ability of the drug to prevent future mood episodes. So not only does a mood stabilizer treat acute episode of mania and depression, it should also have the ability to prevent future episodes
Future.
of mania and depression. Of course, an ideal mood stabilizer is one which would also be able to bring about complete remission from episodes, prevent inter-episodic symptoms between episodes. But as of now, the accepted definition of the term mood stabilizer is to treat acute episodes and prevent future mood episodes. Thank you.
Thank you very much, sir. Dr. Paresh Shah has asked when endoxifen should be used as a first-line treatment. I think Dr. Debashish and Dr. Keshwan have already answered. Could you just give us a one-liner answer to that, please? Debashish or Dr. Keshwan?
Yeah, what was the question? Would you please come again?
When endoxifen should be used as first-line treatment?
It's primarily it's there. We haven't done any study concerning the positioning of endoxifen, about the predictors of good response to endoxifen.
The niche, yeah.
What has been hypothesized is some women may respond or may get greater benefits of endoxifen. People who have hassles with tamoxifen metabolism, and primarily, and it can be used as a first-line drug across all ages because of its safety and tolerability.
Right. Okay. We now have the last question from Dr. Chaudhary. ECTs with endoxifen, is it additive? Any evidence of that? Dr. Andrade, Dr. Debashish.
So, since you're asking me, I will say that there is no evidence. But having said so, ECT is such a potent treatment that there is nothing which is additive with ECT. ECT by itself will produce almost a ceiling therapeutic effect. The antidepressant, the mood stabilizer, the antipsychotic, or whatever drug is given along with ECT will only continue working once ECT has been stopped.
Right. Okay. I have reached the end of my questions, and can I, in the time when I discuss with my colleagues about the best question, which will earn the is that right English? The questioner would, person asking the question would earn a 5,000 rupees Amazon voucher. Can I just ask for some constructive criticism of the program and also endoxifen, that people who have been listening in can give us feedback, any constructive feedback? Anybody would like to speak? Can somebody in the back office see if somebody raised their hand and allow them to speak? Because I can't actually see it from here.
Sport team, is it possible? Sport team.
Sorry?
Technical team, is it possible? Technical team, please help.
Yeah, that's what I'm asking the technical team. Can you unmute somebody to give constructive criticism?
Also, may I suggest a participant can even write a comment fast on the same screen in which he's chatted, and that can be read out by Dr. Anukan Mittal.
Yeah.
So it's
any
critique. It's a constructive critique on endoxifen or on the entire program that has been done today, focusing on the science. We will wait for 5 minutes, else we will close this chapter.
Right. Any comments? Anybody has any comments about endoxifen or the treatment of bipolar disorder. You have experts here today. Dr. Keshwan is here. Dr. Andrade is here of all the people. We have Dr. Debashish Rai. We have Dr. Rajesh Nagpal, experts and well-read researchers with good research experience and who can understand the research, unlike us. We can ask them questions about the new kid on the block. Dr. Avinash is around. So we can get an idea of what we are going to be using and why we are going to be using it in the future and how effective it will be for us. In any case, by the time you decide that, I would like to go back to the questions, and I think the best question that we have chosen is asked by Dr. Prashant Sunil Chaudhary, and that was actually the first question that was asked, that since there are multiple mechanisms for lithium in mania, does success of endoxifen point towards specific molecular mechanism for pathophysiology of mania? And I felt that was one of the more relevant questions asked. So Dr. Prashant Chaudhary, if you would get in touch with the backend team, probably you are, congratulations, the winner of the Amazon voucher for 5,000 rupees. And if by now anybody would like, I do not see any comments in the chat box, neither do I see anybody raising their hand.
Sir, we
So
had one
thank
comment.
you very much.
I'm
Yeah,
posting you the
please.
comment, sir.
Yeah, okay. Thank you. Right. When we talk about a target like protein kinase C, does it also translate into being more specific towards cause than symptoms? And how ironic it is that specificity comes with such a universal enzyme. Right, exactly. I mean, Dr. Andrade has already commented on the part of this, that, the various disorders and various situations in which PKC is disordered or has a role to play, it is very unlikely that it would be a specific marker. Am I right, Dr. Andrade?
That's right.
So I don't think that it is pointing towards any specificity of causality in any way, but it is, as all in psychiatry is, more of serendipity and chance that there is an association, and we will come to know with time whether it is specific and sensitive or not. So thank you, everybody. Thank you very much, Dr. Andrade, especially to Dr. Andrade, because after an arduous trek into the Himalayas with obvious and very enviable sunburn, he has managed to put together such a erudite presentation. To Dr. Keshwan, who from NIMHANS has taken time off and actually worked on such a elaborate fashion on his presentation. To Dr. Debashish Rai, who in this pandemic situation has taken time with Dr. Avinash to spend time actually talking and debating about the specific benefits that we can look forward to this new drug. And also to Dr. Venugopal Jhamar for sharing his expert experiences of using this drug and working this drug in its initial testing phase. So we had somebody who has actually hands-on experience with the drug and is not just quoting from books and references. And most of all, I would like to thank Dr. Rajesh Nagpal as one of the directors of Banai to have put this whole thing together. And last but not the least, to Mr. Jagrup from Entrust, who with his unrestricted educational grant made it possible for us to bring this together at such a time, such a specific thing when everybody's talking of COVID and COVID treatments and COVID pandemics and everything. We are looking forward to restarting our practices, restarting our psychiatric careers with newer drugs and newer lines of treatment. Can I invite Mr. Jagrup to say a couple of words? Mr. Jagrup, are you around?
Good evening, sir. Good evening. Yes, sir. I'm there, sir.
Yeah,
So,
please.
sir, first of all, I thank Banai for arranging such a wonderful webinar and bringing such a wonderful faculty. And because of that, till now, more than 165 people are on live, sir. And besides that, some people will be on YouTube also. So wonderful attendance because of such an informative webinar. Thank you, sir. Thank you very much. And as in most of the discussion, there was a common query that as per regarding long-term data. That soon we are going to start a long-term maintenance study for 6 months, right? In Indian setting in 30 very, very reputed centers. So just to in morning or this protocol part has already been discussed between 25 eminent psychiatrists like you. And another thing, sir, as for the side effect of endoxifen is concerned, as in hormone, like so many hormonal side effects, we have a learning from Dr. Imran, who has done lot of hard work behind this molecule. He says that 8 milligram is too low dose for the for hormonal-like side effect or SCRM activity. So with this, I will request to my SB head, Mr. Anikizen, to give a few more words.
Thank you, Jagrup. Thank you very much for your insight. And at the outset, let me thank you, Dr. Rajesh Nagpal, for setting the tone. Dr. Chitranjan and Rade sir, then Dr. Venugopal Jamwar. I think he's not there right now, but he has given real-world experience with this molecule. Dr. Muralidharan Keshwan, Dr. Devashish Rai for making wonderful presentation on endoxifen, and Dr. Avinash D'Souza because he was also part of debate. At the end of the day, Dr. Anukant Mittal, who was our good moderator, and we have tried to give all the answer. My only request that I keep on telling that yes, we have limited data of 21 days. The group told you that soon we are going to start 6 month study, 6 month, 42 plus 6 month, around 8 month study on endoxifen, which will solve many of queries which you have raised during this time. And data is limited, but nevertheless, we are now completing our trial in US also. All the possibility is there that by beginning of next year, we are going to file our paper in US also. Then we will be moving to regulated market. So company is very I should say that very serious in terms of making investment on this molecule. And we feel that this molecule has definitely good future in bipolar 1 disorder and acute mania. And rest, sir, I must appreciate all the delegates, 170 delegates who have participated in this program, and for their patience hearing, patience listening to all the speakers. And I would request all the panelists and all the delegates, they must give fair trial to this drug, because that will give us more learning that where this drug is effective and where we can use more and what kind of profile this drug will have in future. So with this limited note, my thanks to my INTAS team, INTAS Jonalta team, One Studio team, my medical team for sparing that valuable time on Sunday evening. And once again, thank you very much, all of you, sir. Now over to Dr. Rajesh Nagpal. Thank you.
So thank you for a very scintillating evening. Thank you, INTAS, for unrestricted grant for running this webinar. We hope there will be many more webinars in the future, focusing not just on bipolar disorder, but a host of other illnesses. Psychiatrists seem to like purely academic topics, and we welcome Mr. Jain in this regard to make a final comment in this regard before I close.
Hello. Hello.
Yes, sir.
Yes, sir. We assure you, sir, in future also we continue to arrange this type of webinars, conclaves. We are always there when it comes to science, because this company is largely driven by science. If we have become today, I should say, $3 billion company because of your unstinted and relentless sports in India and abroad. So we will continue, sir. I promise we will continue this type of webinar maybe on other topics as well. Thank you very much, Dr. Nagpal.
Thank you, a very erudite faculty, for having participated. Thank you for your support. Thank you, participants, for your very active support and very interesting questions raised. Thank you, the entire team behind it, including MidSquare and the team behind the technicalities of INTAS. Thank you very much and a very good night.